moving to our afternoon sessions. In the afternoon, is going to be focusing on dementia-related illness from multiple angles. It was very good to have Arlan at noon to show you rapamycin and the effect on cognition. The rest of the afternoon will be Dr. Don Royall bringing a lot of excitement into what the latest development into challenges and diagnosis. But I think the piece that we're looking for Don to update you is amazing breakthrough research and findings that he is working on and breaking through, like always done, is 10 years ahead of the ball game, and helping us to see a little bit of what we got in Korea too about the future of this disease and the medical aspects, followed by, we're going to have Dr. Veronica Shed working complementary to update the components of the neuropsychological testing and how to use that clinically. But it's going to be very good to hear what Dr. Royall will need to say about that too and what we are finding with the latest research. So thank you for being here. He got so many titles, but he's leading our geropsychiatry department right now. He got multiple appointments in the Health Science Center and the VA, and has a tremendous record in research in Alzheimer's and working with the Texas Alzheimer Research Consortium in our Hispanic community. And I could spend the rest of the hour talking about how wonderful mentor he is and what a great asset for science in the current time. So thank you, Don, for giving us an hour of your time on this.
Well, that was quite an introduction. I like to say that I went to A&M, and the Aggies taught me everything I know about dementia. That was before I went to medical school. So, I thought I'd just review dementia for you here a little bit. And so, basically, it's called Alzheimer's disease because it was discovered by Alois Alzheimer's at the turn of the last century. And he was in the right place at the right time. They were inventing new stains then in Germany, new chemicals. It was part of the revolutions in chemistry that were going on then. And with these new stains, he was able to identify for the first time these two lesions in the brains of people that clinically had dementia. And this is the amyloid plaque here, which we now know is composed of these amyloid, beta-amyloid fibrils. And this is the tangle, which is made out of tau. Now, I think a lot of people may be fundamentally misunderstanding what's going on in Alzheimer's, because Arlen kept conflating aging with Alzheimer's. But you should realize that in old animals, they don't get these lesions. So old giraffes, lions, tigers, orangutans, chimpanzees, they don't have Alzheimer's pathology when they get old in their brains. There are only humans, and then 3 domesticated species, sheep, goats, and cows, get especially tangles as they get older. And so if you have a theory for what's causing Alzheimer's, you have to explain that. And so there are a lot of little factoids about Alzheimer's that don't get widely appreciated, and they're not part of people's thinking. So if you want to say that Alzheimer's is aging, then you have to explain why old animals don't get it, right? And so another interesting thing is that the animal models of Alzheimer's are engineered to make these lesions, right? By taking human genes and sticking them into the mice or the rats. Otherwise, they wouldn't make these things when they get old. And so that means it's fundamentally not really the same process, because, as I'll show you, Alzheimer's pathology is very precise in the regions that it affects and the sequence that it gets there. And that's another clue to what's going on in Alzheimer's. And that doesn't happen in the engineered animals, because the engineered animals are just designed to pump out these proteins all the time, and it's under no real biological systemic control, so it's sort of out of control, and their brains just fill up with this stuff and they get memory impairment. But that's not really what happens in people. So in people, tangles are spreading stepwise through the brains following the wiring. So tangles start in the nose, or the olfactory cortex. That would be the first place, way over here somewhere, and proceed retrogradely, transsynaptically, following the synapses. So the regions of interest that are wired together succumb in sequence, like dominoes. And that's why Alzheimer's has a story. It has a natural history. It has a beginning, a middle, and an end. And the sequence of symptoms is stereotyped. And it's so stereotyped that we can recognize it as a syndrome as clinicians. So Alzheimer's story begins somewhere and ends somewhere, and it turns out that that sequence follows the spread of the tangles through the brain, right? So this is a data set from France. This is 128 autopsies in a geriatric service in France, and each column is a case, and each row is a region of interest in the brain. And what they've coded for you here is whether or not there's tau, which is the chemical that makes up tangles. Now, other researchers in Europe had shown that tangles follow the same sort of progression. I think this was the first time they showed that the lesion that makes the tau does the same thing, right? So it starts out here in the hippocampus, right? And you can see that every one of these cases has hippocampal pathology. But up here, I've coded for you if they were demented before they died. You see? And so when I looked at this data, I published a paper in about 1999 trying to say the magical question, which step in the progression of the disease accounts for the presence or absence of dementia after you adjust for all the other pathology in the brain? You see, because it lended itself to that. And basically it turned out the 7th step explained 90% of the variance in who was demented and who wasn't after adjusting for all the other tangles in the brain. Now, up to then, everybody kind of thought it was the weight of the tangles, you know, just the aggregate sum of all the damages in the brain that make you demented. But what this was able to tell you is that dementia lives in a place in the brain. All of this pathology before step 7 is insufficient for dementia. And all of the pathology afterwards is unnecessary because you're already demented, even though it goes on to hit region 8, 9, 10, right? And so this is the cortex here, out here, and this is the hippocampus, that's way back here. The hippocampus was the only region whose pathology was not significantly related to dementia status at all, because it's too early in the sequence. The hippocampus is affected years, maybe decades, before you become demented, so its pathology is irrelevant to your dementia status. Right? And that's what I meant by in Hawaii, 89% of the brains have tangles in the hippocampus regardless of their clinical status. Only 3% of those 1,000 brains were demented at the time they died. But 89% had tangles in the hippocampus. So the hippocampus may be important for memory function. Memory function precedes dementia as an artifact of the progression of tangles. And not only that, this progression is only relevant to Alzheimer's. So this story of memory loss first, and then it gets worse and worse and worse, and eventually you become demented, is an Alzheimer's story. Outside of Alzheimer's, it has no validity at all, because why would any other disease cause tangles and have them spread through your brain like that? It just doesn't happen. Not in Lewy body, not in vascular disease. So vascular disease is random. You just throw the dice, and the next day you wake up with a new stroke, and it could do anything. A stroke could make you blind, or have hemiparesis, or make you lose your memory, or make you lose your language, or make you lose your whatever. You might become depressed or apathetic. So there is no story to vascular dementia. It has no beginning, it has no middle, it has no end. It's just a random compilation of things related to ischemic lesions on the MRI. But Alzheimer's has a story, and that story is the invasion of the brain from a portal of entry in the first cranial nerve, your sense of smell. So the first symptom of Alzheimer's is to lose your sense of smell, and by the time you're demented, you better show me that he can't smell. Because if he's demented and can still smell, then he didn't get to dementia through this particular story. And so it's probably not going to be Alzheimer's. So that step, the 7th step, is the key step, and it involves 4 regions of interest. So I'll go back and just show you here. 1, 2, 3, 4. It's the only step that involved more than one region of interest, right? And so I'll show you in a minute where that was. Now, here are 1,000 brains from the Honolulu, oh no, that's 400 brains from the Honolulu Asia Aging Study. And we were able to build a model of how the tangles spread through the brain in each one of these individuals. And we applied the math for what are called growth curve models of longitudinal change in cognition to the spread of tangles. So we're looking at the way tangles spread in space, meaning the brain, instead of the way they spread in time, which you can't measure at autopsy because you only get one peak at the autopsy. But we applied the same math. Math doesn't care. The math treats a dimension as a dimension. So basically, what you can see is all these people can have huge numbers of tangles in the hippocampus. This is the average here. And as you go deeper in the brain, there are fewer and fewer and fewer tangles on average. And but way back here in the hippocampus in CA1, there are very, very, very high numbers, and only 3% of these 400 people were demented. You see, despite the fact that they have huge amounts of tangles back in the hippocampus. The subiculum here is only 1 synapse away from CA1, but it is the output from the hippocampus to the cortex, right? So basically, in one step, you go 3/4 of the way to the very worst case of cortical involvement by tangles you can get. In other words, the only road from the hippocampus to the frontal lobe goes through the subiculum, and there are much smaller numbers of tangles in the subiculum. So I think there's a dam in the hippocampus blocking tangle formation from getting out. And behind the wall, which is here at the subiculum, tangle counts just keep going up, 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 but it has no consequences, no implication for your future dementia, because to become demented, it has to get out of the hippocampus into the cortex, because that's where the critical regions of interest are. And it can't get there from here, so the tangles just pile up and up and up and up and up. But in this very small fraction who have tangles in the subiculum, every one of the dementia cases came from that group, because it has to get through that wall to get down into to the rest of the cortex. So here are the key regions of interest. There were 4 in this study, and this is where they are. They're the default mode network. And let's see if I get this right. I'm standing backwards here. So, right, posterior cingulate, anterior cingulate, temporal, superior temporal gyrus, dorsolateral prefrontal cortex, and the angular gyrus. So, so when I found that in 1999, that there are only 4 regions of the brain which are the key step, which correctly classify 90% of cases as demented or not after you adjust for every other tangle in the brain, then I realized that dementia lives in a location, and that location is this default mode network. In 1999, well, so I Googled it. I said, oh my gosh, show me every abstract ever published, every paper that has these 4 regions of interest in the same abstract. And there was only one. And that one was a monkey study where they lesioned the brain here, and each of these other regions died back. And because they're connected by 1 synapse. So all I could say is dementia is critically associated not with global pathology, but with the involvement of 4 particular regions of interest that are separated by 1 synapse. So there is a network. There's a network. So there must be a key network that is essential to dementia. And nobody believed that. I mean, 1999, the world is thinking that Alzheimer's is mostly amyloid and it's the aggregate sum of all the lesions. So I couldn't get that published except in an out-of-the-way journal. And I don't think anybody's ever read that paper. And furthermore, the default mode network hadn't been named yet. And so it turns out about 5 years later, Peter Fox, who's here now and the head of the imaging center, had, with a bunch of other people in St. Louis where he trained, noticed that they were doing then functional imaging studies where they would stimulate the brain somehow, the psychologist would give you a task, and some part of the brain would light up. And if it was the memory task, then the memory centers would light up, and we would know where they are. And if it was depression, then the depression centers would light up, and we'd know where they were. But all over the world, no matter what language the task was given in, no matter what the task was, there's a control group. And the control group is just asked to lie in the machine and we'll be back in a while. And in that group, all over the world, the pattern looked exactly the same. And it was this pattern right here. And so they called it the default mode network. They didn't know anything about it. But as soon as I saw it, I said, that's my network. Wow. You know, the default mode network is the network whose pathology gives you dementia. Because no other tangle is important. The tangles before they get here are insufficient for dementia, and the tangles after they go through here are unnecessary for dementia. So basically, this is the key network. It's the part of the brain that is on when the psychologist is not giving you a test. And as soon as the psychologist gives you a test, it turns off. And it's what they call anti-correlated with this other. These blue areas are the opposite of the default mode network. They turn on when the psychologist gives you a test. But when you lie there alone, then the default mode network turns on, right? And so basically what this means is you can't screen for dementia with a cognitive test. Because as soon as you do, you're not checking the key network anymore. You're checking some other network. And now maybe Alzheimer's has eaten that one up, and you can find memory loss, but the memory loss is not why they're demented. They're demented because of this network that is actually relatively hard to assess through cognitive testing. And we're getting around that now. But that's basically a fundamental critique of thinking of dementia as cognitive impairment. And I think that's why nobody has succeeded in defining dementia solely on the basis of cognitive tests. You gotta have your clinician there, because the clinician provides some extra je ne sais quoi that allows you to get past the numbers to, I don't care what the numbers say, just look at him, he's demented, right? Or the other way around, which is he's demented and I don't care what the numbers say, you know, because there are a lot of people who are, you just know are demented and yet their testing looks normal, right? Both problems exist. And so I think the reason for that is that the key network is not amenable to interrogation by cognitive tasks, right? And another thing I'll say is that the entire psychometric enterprise is really only about 150 years old. I mean, there was no such thing as psychology until about 1870. And when Alzheimer was working, they barely had anything like cognitive tests, right? They were just barely talking about psychology then. Right? So when he said it was dementia, right, he wasn't talking about memory loss. And his patients were young. He wasn't even talking about old age. The word dementia is 500 years old, right? They were using the word dementia in psychiatry and medicine years and years and years before memory loss was conceived as a cognitive discipline or disorder. And basically, what they meant by it was disability due to mental illness, not memory loss. So the word dementia, its roots are in incapacity, becoming incapacitated. And that's still echoing around in our thinking about dementia. Dementia isn't just memory loss, it's disability due to memory loss, right? It's the disabling fraction. And it turns out that the default mode network is also the seat of functional status, of IDLs. It's the part of the brain whose function is most necessary to the complex goal-directed activities that we call doing your homework, right? And that's another difference between dementia and cognition. Cognition is what you can do here and now in the room with the psychologist, because I give you the piece of paper and you do the math problem. But cleaning your room, or doing your taxes, or doing your finances, or managing your meds is not something you can do here and now. It is something that has to be done there and then in a future that you imagine where the room is clean, or the dinner is cooked, or the taxes are filed. And you have to navigate from here and now to this imagined future where stuff happens. Right? And that's what we call functional status. Functional status is inherently future-oriented, and this network is important for that. So, then we started finding studies like this. Arlen told you there's hypometabolism in the brain of Alzheimer's patients. What he didn't tell you is it's not random, like the amyloid models in the mouse. It's limited to the default mode network. Do you see? It's the very same region whose pathology is related to dementia in my model. And here, are the hubs of the default mode network. Look how well they correspond to the regions of the brain that are dysfunctional in demented patients when compared to controls, to non-demented patients. The hippocampus isn't in here because its metabolism does not discriminate demented patients from controls. Because half the controls have tangles in the hippocampus, right? And so you can't distinguish them on that basis. So this here are the places in the brain where one stroke will give you dementia. It's the same regions. Posterior cingulate, anterior cingulate, middle temporal here. Oh, this is posterior, this is anterior. That's dorsolateral. That's angular gyrus. Right? So it's the same network too. And how did I get in there? Oh, well, so this is the stepwise progression. Oh, and so your theory of dementia has to accommodate that. And basically, what I think you should be thinking of is viruses. Because viruses do progress retrogradely and transsynaptically through the brain. And host-parasite relationships are species-specific. So I told you the tangles only develop in humans. And then 3 domesticated animals, each of which has a herpetic encephalopathy that jumped from us to them in history since their domestication. Those are the only animals that get tangles as they get old. And finally, humans are challenged by a family of herpes viruses that are human-specific pathogens that have co-evolved with us for 1.5 million years, and living inside a human nervous system is all they do. All the time. That's their thing, right? So now, pathologists use herpes viruses to track neuronal networks. They used to poison them. They used to put in a poison, and it would kill one neuron back, and you'd have one little piece of your network, and then you'd have to go in there and put the same poison into that region, and then see what it plugged into. And slowly and painstakingly, you could build up the sequence of regions of interest that make up a network. Now, they just take a herpes virus, stick it into whatever part of the brain you want, and see where it goes. Because where it goes is the wiring. Because they're that good at it, right? And so basically, herpes viruses are strong candidates because they would explain the stepwise retrograde transsynaptic propagation of networks through the brains, and also simultaneously why it's a human-specific problem and not just old animals, living in zoos. So herpes simplex, just as an interesting aside here, affects 100% of humans by adulthood. All over the world, we're all affected. 80% of cadaveric cranial nerves have herpes simplex DNA in them. 40% of non-demented controls have herpes simplex in the cortex and by DNA, and 70% of Alzheimer's cases. So being demented doubles your risk of having herpes simplex all the way into your cortex, as opposed to extracranially in a cranial nerve. Herpes genome is found in more than half of Alzheimer's cases tested by PCR. If you are an ApoE4 carrier, it increases the risk of herpes simplex in your brain. I think it's 1,200-fold if you're an E4 positive. If we find herpes simplex in your brain, then the chances you're an E4 are 10 times higher. So there's something about E4 that favors the infection of the brain by herpes simplex. We're all infected extracranially. And it's recently been found that the genome of herpes simplex is co-localized with amyloid plaques, and that there are HSV fragments in the amyloid plaques. If you have mouth sores from E4, it's a risk factor for Alzheimer's disease. And this is a really interesting review. Of 28,000 human proteins, only 330 or so are known to be used by herpes simplex at some point in its life cycle. 60% of those proteins are risk factors for Alzheimer's now. 60% of this 300 here. 40% are present in plaques of tangles of these proteins here that herpes simplex uses. So, I've been working on this idea that this is a great quote. The brain, like a castle, divided into many towers and places of defense, is thereby made stronger and harder to be taken. So your brain is like a fortress, and it has certain openings, certain portals of entry. Anything that goes in through the walls can land randomly in the brain. That would be the blood-brain barrier. So stroke is something that just knocks down walls and gets in. So it has no story, no beginning, no middle, no end. But if you come into the castle through a gate, then the castle reveals itself to you as an architectural space in a certain sequence that is determined entirely by the portal of entry. And so for a retrogradely invading pathogen, of which human beings are particularly prone to a family of herpes viruses that knows how to do this trick, then the regions of interest that succumb will succumb in a particular order, and that leads to a particular pattern of propagation and the recognition of a different syndrome. So, so basically, Alzheimer's, as a result, may have a particular story, and it's the typical story that we associate with dementia. It's what the Alzheimer's Association talks about. It's the fast stages, right? But this story will have no relevance if something came in a different portal of entry. And how many are there? There's at least 12 cranial nerves. So the Alzheimer's story can be explained by something propagating through the first cranial nerve. But there are examples of several of the others. And one of them is Lewy body. So Lewy body disease appears to be entering the brain along the 10th cranial nerve. And its pathology is distributed along that network. And its symptoms are related to a pathogen expanding within that network. And so the beginning of Lewy body disease has actually been shown to be extracranial. And then to invade the brain along the nerves, these are now sympathetic autonomic nerves that innervate these organs. So it turns out that Lewy bodies can be shown pre-clinically in the SA node, and if they're in the SA node, they're associated with idiopathic atrial fibrillation. And AFib is a risk factor for future Parkinson's and Lewy body disease. If you have idiopathic, meaning you don't have valvular disease or anything, just an old guy who gets AFib, the odds are 60% higher that you'll develop Lewy body or Parkinson's before you die. So it's a risk factor for that. And so you can follow the wiring up through the autonomic nervous system, and this is the pattern that Lewy bodies approach the brain in. Here are genes that are known to be associated with atrial fibrillation, and here's the fraction of those that are also risk factors for Parkinson's disease. And here are the fraction of those that are risk factors for CMV infections, another herpes virus. So if you crossed Parkinson's and AFib with herpes simplex, you wouldn't get any hits. Or, I've done all that. So Epstein-Barr, no hits. But you get to CMV, and basically there's overlap between the genes that are associated with AFib, the genes that are associated also with Parkinson's, and finally, thirdly, with CMV infection. So that would be my best deal with that. And there isn't just the heart to think about. There's multiple organs that lead through the sympathetic nervous system to the brain. The Lewy bodies are found in the extracranial sympathetic ganglia that supply all of these organs. There are Lewy bodies in, in the stomach and the intestine, in the solar plexus here and the celiac plexus that are related to chronic constipation. So Parkinson's patients often report years of constipation before they declare their CNS features. And in the esophagus, they're in the gastroesophageal junction, and that's associated with GERD. And in the heart, it's the SA node, and they're associated with AFib, like I said. So now, how can we understand what dementia is? Because if it's not really memory loss, and it's not really the cognitive testing per se, then what is it? Well, it's global cognitive impairment, and I think the emphasis here is on the idea of global. So if you had just memory loss, you wouldn't be demented. If you had just aphasia, you wouldn't be demented. There has to be something more global going on. In a clear sensorium, so you're not delirious, and sufficient to cause disability. If you're not disabled by it, then it doesn't really matter what the cognitive tests show, you're not demented. Now there are intermediate stages people talk about, like mild cognitive impairment, MCI, where the psychometric tests show some impairment, but you're not yet disabled, right? So we can actually build models of that and put it in a bottle where you can start to examine it. And the way we do that is through what are called structural equation models. And they look outrageous, but they're really not all that hard to understand. So in a structural equation model, a square variable is something you measure, and then a circle is a latent variable or a factor that is what they share, right? But you can't measure that directly. So it's a circle to distinguish it. And so what I did for you here is I built a bunch of cognitive measures. This is data from the Texas Alzheimer's Research Consortium. So that's like 2,000 people in 5 different medical schools in Texas, followed longitudinally. 1/3 of them are Alzheimer's cases, so that's about 800 or 900, and 1/3 of them are Mexican American. Right? So here's a cognitive battery, and here is what they all share. And that's been talked about in the literature for 100 years as what's called general intelligence, or G. General intelligence is the variance in a cognitive battery that is shared across all the tests. And people have shown a long time ago that it doesn't really matter what tests you got. All tests are tests of general intelligence. And then after you adjust for G, what's left over might be memory. Memory is not shared by every test. Not every test is a memory test. But every test, as far as we can tell, just about, is a G test. And that becomes useful and interesting later. Anyway, here's functional status. These are the instrumental activities of daily living. Here are the activities of daily living. And they all share something that I just called F for functional status, right? And then here is dementia, which is what cognition shares with functional status, right? So we can define a latent variable for that, and that's D for dementia. So what you can see here is that D is disproportionately responsible for clinical dementia status. This is the clinical dementia rating scale that an expert sat down with the family and the patient and developed their stage of Alzheimer's, if you will. That correlates 0.9 with the D score, but is not significantly related to general intelligence, nor is it really related to functional status. Because this would be the fraction of variance in this battery not related to functional status. And this is the fraction of functional status not related to cognition. But this is the only place where cognition and functional status can be related. And so that puts dementia in a bottle. It's a very strong predictor of dementia status. So once we have this latent variable that seems mystical and you can't work with it very easily, it can be output, though, as a score, your dementia score, right? And that's just a simple multivariate regression. So it's some factor weight, so it's logical memory times 0.5 plus visual recall times 0.7 plus verbal fluency times 0.3 plus, so there's some secret formula, right? It's too much to look at. You can't look at it in the test scores and see it because it's a latent variable across the entire battery. But I can sure as hell write it into a phone app, right? And then once you got that, you can just get these scores in the field and upload the raw scores into the phone app, and bingo, it calculates your dementia score. And it turns out that this is much better than either clinicians or psychometric batteries at predicting who's demented. And not only that, but because D is a piece of G, D is the piece of general intelligence that is in fact related to functional status, whereas G prime here is the residual fraction of general intelligence that has no relationship to functional status. So this fraction of cognitive performance is irrelevant to dementia status, and this is where it all is, right? Well, it turns out D explains about 40% of the variance in any battery, and G is another 40%. And then there's measurement error out there somewhere, you know, education bias, linguistic bias, cultural bias, all sorts of bias. So you add all that up, and what it means is that a minority of variance in any battery is related to dementia, and most of it is measurement error, because it doesn't inform your patient's dementia status. But the only piece that is can be bottled up this way and then described by a very simple equation that we can put into a phone app. So here is D's ROC curve in TARC for diagnosing Alzheimer's versus controls. It's perfect because it is dementia. It's the only piece of cognition relevant to dementia. And so its ROC is exceptionally strong. Here's what's left of cognitive performance. This is actually the majority of the variance in the battery. Its ROC is useless. 0.5 would be flipping a coin, right? So what this is telling you is that most cognitive performance is actually irrelevant to your dementia status. A little piece is highly relevant, but you can't tell in the raw numbers which piece you're looking at. You see? So unless you take a latent variable approach, you're just not going to get there. Once we have dementia in a bottle, this is a completely different data set, completely different battery. We built D the same way. It still correlates uniquely, strongly with the dementia status. But in this data set, we had imaging, so we could image D. And here are the gray matter areas in the brain whose atrophy is related to the D score, right? It's the default mode network again. So now everything's come back full circle. Before, I had neuropathology. Which tangles predict dementia status as adjudicated by clinicians? Now I have a psychometric construct which captures the cognitive correlates of functional status. Both of them map to the same network in the brain, the default mode network. And that network cannot be interrogated by cognitive testing, which is why so little of the variance in any battery you could imagine is going to predict functional status and therefore who's demented. And then it turns out that amyloid is co-localized in the default mode network. Because unlike the mouse model, the amyloid in human beings does not develop randomly, just like the tangles don't develop randomly. But the amyloid doesn't develop in the same place as the tangles develop. The tangles start in your nose and eat their way back, retrogradely and transsynaptically following the wiring. Lewy bodies are eating you up from the vagus nerve up, coming through a different network in a different sequence. The amyloid is in a third network, different than the other two. It starts out in the default mode network, the key network. So if amyloid was bad, why wouldn't you get dementia? Because my association was with tangles. And the tangles don't get there until you become demented after years and years and years of coming up from your nose. The average age of onset of tangles in your olfactory cortex is about 50. So 50% of the population has tangles already in the olfactory cortex by age 50. But who cares? It's nowhere near your default mode network. But they're encroaching on it little by little. In a few years, you'll have memory loss. Then it'll get in the insula and the amygdala, and you get cranky. God damn it, I don't know why I have to take these tests. Right? Then it gets into the posterior cingulate, and you start having trouble with driving, just like Arlen said. Because the posterior cingulate, which is right here, is part of the default mode network, but it's also part of a visual network that starts in the occipital lobe and projects through the posterior cingulate on its way to the frontal lobe, because it's wired into your upper visual field and is paying attention of your location in space, right, as you navigate. Because up high in the sky are objects and clues and signs that might be to your survival advantage, like smoke or clouds, you know, or birds circling. But they're all in your future because they're nowhere near you, right? By definition, they're way up there. And so you send it to the frontal lobe because it's the part of the brain that thinks about the future, right? But the lower part of your visual field projects to different structures in the brain, and they go to the orbitofrontal area, which is where you process emotional information. Because anything in your lower visual field is right there. God damn, it's a spider! You know, a baby! Oh, how cute. See, so they're emotional things. Things that are close to you are emotional, and so a different visual network processes it because you have to act fast. He's going to drop that, right? Look at the brake lights. So an Alzheimer's patient has trouble driving, but it's this very laid-back, no emotional problem of your wife becomes the navigator, right? And so you don't know anymore where Culebra is, but she's going to turn left at the next light, dear, and so you turn, you know. But the Lewy body patient, it's in the autonomic network, and that's much more emotional. And so in Lewy body disease, they ignore the brake lights of the car in front of them, or the little kid whose ball bounces into the highway, because it's the lower visual field that's degrading in them. And so there you have a caregiver who's got their knuckles on the, you know, stop! You know. And so it's a completely different experience in Lewy body than in Alzheimer's disease, the sort of driving problems that they get into. They both have driving problems, but they're based on the anatomy of the network succumbing to the pathology, see? And so you get a different story. So basically, A beta is put down in the default mode network, and I think it's a defense. Because it's like a landmine. A beta, the beta amyloid itself doesn't do anything. I mean, beta amyloid is in the key network decades before you even have cognitive impairment. Right? So its mere presence does not necessarily lead to any clinical features. Right? Even though it's in the key network, right? That's because the amyloid form of it is stable and very chemically neutral and doesn't do anything. They recently had the 100th anniversary of Alzheimer and his work, and they went back to his lab and they found the slides that he diagnosed and published, you know, with little line drawings, pen and ink drawings in 1909, and you can still see the same lesions that he drew. Because they're so stable, you can hardly wash them out. Nothing, they don't age, nothing breaks them up, nothing melts them, nothing, you know, they're highly, highly resistant to all sorts of things that would normally just eat organic materials, you know. So they didn't fade away, right? But the amyloid is basically a plaque, is basically a beta pleated sheet composed of multiple protein units that aggregate spontaneously into this giant package called the amyloid plaque. And it's the little bitty pieces that turn out to be inflammatory and nasty. These little bitty pieces incite inflammation and reduce synaptic density and do all sorts of other nasty things, kill neurons, activate macrophages. They do 1,000,001 things. And so the little pieces are what matter. And so I think this is acting like a landmine. It's a passive defense that protects a key territory, which is the default mode network. If the tangles ever get in here, you're demented. This is the only region whose tangle pathology is associated with dementia. And the tangles are coming up the highway from the nose. And the default mode network is one of the most highly interconnected regions in the brain. It's inherently vulnerable to viral predation along a neural network. Any neural network. All roads lead to Rome. All roads lead to the default mode network. So I think nature has given us a defense. And what I like about thinking about amyloid this way is it also gets you over another problem, which is proteins don't misfold. Every protein folds exactly how it's designed to fold. Right? Unless you're talking about a mutation, proteins just don't misfold. Now, they may do nasty things, but that doesn't mean they're misfolding, right? And sometimes nature does nasty things for a reason. So, sickle cell anemia is not a disease. It's an adaptation. And it's an adaptation to predation by an infectious agent, malaria. And nature gave us sickle cell anemia because the alternative is worse. And so even though sickle cell anemia is not a picnic, it's still better than the alternative, you see? And so that's what I'm thinking Alzheimer's is. Alzheimer's is better than the alternative, and the alternative is encephalitis, which is why all of the interventions against amyloid are failing, And sometimes they flame out floridly in encephalitis and death. You see? So I think basically you're messing with fire if you're messing with amyloid. And that's what scares me about rapamycin and why I'm not just rushing out to give it to everybody and their grandmother. I've only given it to a few people who are so close to institutionalization, they have no other option. And if they flame out, then, well, you know, you had your chance, right? But if they had benefit, I might delay their institutionalization. You see? So that's my attitude about that, is that there's more going on with amyloid than a lot of people think. And in humans, you have to think about the third party. You have to think about the virus, because it has a vote too. And I'd be scared to death to fiddle with innate immunological defenses against human viral pathogens, because I know our brains are actually full of them. And they're human problems, not just any old animal problems. So this is D's distribution in the brain, which is also the default mode network. See? So this is the key dementing region in the brain, and that's where the amyloid is, right here. So the amyloid is there years before you're demented, so it's not inherently bad on its face. Because you can live with amyloid in your brain for 10, 20, 30 years, even though you know, you're at risk for dementia the whole time. I mean, this happens particularly in E4 positive people, right? They lay this amyloid down. But the imaging shows it. We can image the amyloid, and paradoxically, they're finding that it's there in normal people who are merely at risk, some indeterminate future risk of Alzheimer's, and not all of them succumb. So, and then I'll show you this. This is a more dramatic way of showing it, but this is a model, well, this is actual data from humans of the longitudinal change in atrophy in the brain as you go from normal to MCI to dementia. So when they first started to, you know, show that they could do this with the MRI, some people out at UCLA made this little picture and put it on the internet. And so you can actually see the literal spread of atrophy through the brain as you become demented. But what I want to show you is that the atrophy is in the regions that don't have amyloid, and that the last places to atrophy are the hubs of the default mode network, which is where the amyloid is laid down. So the atrophy is actually fastest in the motor and sensory strip here that don't have amyloid. The places with the amyloid are resisting the atrophy, and you can literally see it here. Here is a review of all of the active clinical trials, maybe this is a couple of years out of date, for Alzheimer's disease. And in the center here are the ones that are approved, and around that are the ones in phase 3, and around that are the ones in phase 2, phase 1. All of these have failed. And most of these are directed against amyloid. But one after the other, they're flaming out. So I think this means something is fundamentally wrong with our thinking about Alzheimer's. The literature has not come to that conclusion yet. They keep hoping that it's just because, you know, we didn't have the right cognitive measure, or the placebo group got a little bit too demented too fast, and if we'd only done this better, if the damn clinicians just knew how to diagnose MCI, then it would be better next time. And they just keep flogging away at it. But the way I look at it is there's something really wrong with your model. So we got the Texas Alzheimer's Research Consortium going now, and it's 5 centers in Texas here that are recruiting into a common protocol funded by the state of Texas. We have thousands of people, longitudinal follow-up, a standardized battery at every wave, 150 serum protein biomarkers, and a full GWAS panel. And this data is open to any researcher in Texas, in a Texas institution. All you got to do is fill out like a 2-page request. You can get this data and work with it, right? So you really should do it. And so what I've been doing is getting the biomarkers of the D-score. So I have this D-score thing that has an ROC of 0.999 against clinicians and throws away all the measurement noise and measurement error in the cognitive battery. And so it pures dementia down to its essential feature, and it maps to the default mode network, and now I can get the biomarkers of that. And So basically, we output the D-score. It used to be latent, now it's square, because now it's a measured variable. Now I have the equation that represents the D-score, and I can get the serum protein biomarkers of that. And in this model here, we got 9 hits. 8 are related to innate immunity, which is your natural defense against viruses and microbes. So I think what's happening is these biomarkers show when you wake up your monster. You've been infected since you were 3 years old, just like herpes zoster. And this is what they do. They find a human, they find an extracranial nerve, they crawl up that nerve into the CNS, and they hang out silently for years, 10, 20, 30, 40 years. Every one of us is infected with zoster now in our spinal cords right now, but nobody has any symptoms. But I could find the DNA in there if I wanted to. Right? DNA is there, just like the herpes simplex DNA is in your cortex in non-dementia people. But it's asleep, right? And something has to wake it up. Now, in animals, there is a zoonotic encephalopathy that has jumped from humans to sheep, goats, and cows to 3 other species that get tangles when they get old. And it's a big veterinary problem. So they have actually studied the insults that wake up the monster in these animals, right? And the 3, I mean, they've studied everything: head injury, radiation, chemotherapy, all sorts of stuff. So the 3 things that reliably wake up your monster are fever, stress steroids, and ischemia. So if you let your patient be exposed to fever, stress steroids, or ischemia, you risk to wake up their monster. And if you do wake up their monster, the brain, the immune system, is going to be shocked to find that there are herpes viruses living in my brain or spinal cord. And it's going to do something about it. And when it does that, cytokines go up, you know, amyloid gets laid down, fireworks go off. And you end up with, you know, your zoster lesions. But in the brain, I would say that what you're going to end up with is tangle formation. And it's going to get out of the dam that's blocking it back in the hippocampus. And once it's on the move, then the dominoes are going to fall, and you're going to develop a longitudinal decline that we recognize as Alzheimer's disease, but which is fundamentally an attack on the first cranial nerve by an agent which is propagating. You know, not to say I know it's herpes simplex, but what other options you got? You know, what's your idea? So it turns out that these biomarkers only work in Anglos. They don't work in Mexican Americans. And so here, one of them was thrombopoietin. I think this is thrombopoietin. Serum thrombopoietin levels are very strongly related to your D-score, but only in Anglos. And so you can see there's 2 populations here, and I just guessed that it would be ethnicity that's dividing this, these serum protein thrombopoietin levels into 2 levels. And sure enough, look at this huge ethnic effect. In the Mexican Americans, there is no effect of diagnosis on the levels. But in the Anglos, it drops in MCI and trends back towards normal in the dementia cases. So it's not a linear, it's a non-linear effect. So sure enough, these biomarkers work as a predictor of control versus mild cognitive impairment in non-Hispanics. They have an area under the curve, an ROC of 0.85. Do you know that cognitive tests aren't even that good? But this is just a serum, this is just 8 or 9 proteins that I could measure in the serum and make a diagnostic test out of. And it's almost, it's probably better than an entire cognitive battery at predicting your MCI status. But it doesn't work at all for Hispanics. And if you mix the 2 together, you get some intermediate and not very good looking thing. So this is really wild. This either means that TARC clinicians are misdiagnosing Mexican Americans and they're not really getting Alzheimer's. Or that Mexican Americans get Alzheimer's by other means. And that biologically, they're just not handling the Alzheimer's disease the same way that the Anglos do. Because this is just amazing. We would have completely different biomarkers across ethnicity. But I think one explanation for this might be that modern Mexican Americans uniquely, not Hispanics in general, but Mexican Americans, are all descendants from a choke point in history where the Spaniards came over And the Indians had no exposure to most of their infectious diseases. And so they went through gigantic demographic mortality from epidemics in the 1500s in Mexico. We don't really know how many died. The minimum estimate is 50%, and that would be as bad as the bubonic plague in Europe in the 12th and 13th centuries. But the upward estimates is maybe 90%. So maybe only 1 out of 10 pre-Columbian Indians survived, into the next 100 years. And it was just wave after wave of measles and mumps and chickenpox, and just these things just came at them. And if Alzheimer's is a herpes virus, then it may be that every Mexican American is a survivor of that particular viral pathogen. And from that choke point down to the 1 out of 10 who somehow handled it differently is everybody who we now think of as Mexicans. You see? So I think we may actually have a strong selection for how Mexicans in particular handle infectious diseases, and this might play itself out with all sorts of interesting Hispanic paradoxes, So longevity in Mexican American women is longer than in Anglos, even though they have higher rates of diabetes, less access to health care, terrible rates of smoking, obesity, everything. But they live longer than Anglos do. So that's the Hispanic paradox. So basically, the way I read it, there are a lot of little bitty factoids that should make you just rethink Alzheimer's and various dementias. And it seems more likely to me that they're the result of an infectious pathogen. And I don't know exactly what it is. I'm not really a basic scientist. But as a clinician, I get kind of worried about fiddling with amyloid. I've been doing these clinical trials for years and just reading the side effect profiles of all of these drugs that are flamed out one after the other. And there's no doubt in my mind that they're successfully getting rid of amyloid. The animal models show that. I'm just not sure that's such a good thing. Because fundamentally, I think from an evolutionary point of view, you have to realize that nature doesn't make proteins that misfold. That would be a rare mutation. It would not be the world's second most common cause of mortality in older people, right? So that's just not how nature works. So I'm much more cynical about the possibility to manipulate amyloid. On the other hand, we know where to look in Alzheimer's for the virus, if it is a virus, because of the elegant distribution of the pathology in space and time. So we're much more likely to be able to prove it in Alzheimer's that it's a virus than anything else. But if Alzheimer's goes, I think many age-related diseases are going to end up being infectious. I'll bet you that diabetes is infectious, that atherosclerosis is infectious. And the truth is, old animals in zoos don't get those either. Rats don't get diabetes when they get old, and they don't get atherosclerosis. Neither do giraffes that have blood pressures of 400 over 220 because they're shooting the blood up to 12 feet in the air. So they don't get atherosclerosis. And if you take the heart out of a 20-year-old accident victim and transplant it into a vascular path at age 58 or 9, that heart develops atherosclerosis in its arteries within 18 months. You see? So I think we have to be prepared for a future where all of these so-called aging-related diseases end up being infectious. And I think you ought to remember that, we were promised all these genetic tests for cancer and such. We don't have genetic tests for cancer. We have vaccines for cancer because they too are turning out to be, in many cases, due to infectious agents. So I think the importance of pathogens and parasites for human disease has been, overlooked, and we have to be open to the fact that we don't really have all the answers.
Any questions for Don before we transition to the next part?
Yeah.
For the slow guy in the room, you said there were 3 factors for the onset that kind of triggers.
Oh,
said
yeah.
Fever,
paper, scissors, and
Yeah, that's it, yeah.
no. So it was fever, stress steroids, and ischemia
Okay.
are the three stressors that reliably wake up herpetic infections in the CNS.
So if I avoid those three,
Yeah. So.
I'm golden, right?
Well, I don't know. I mean, everybody's at some risk for. I mean, all humans are infected by these agents. So if dementia is due to them, then we're all pretty much messed up. But on the other hand, a whole lot of people have the pathologies and are not demented. So, nature and its wisdom, compared to encephalitis, Alzheimer's doesn't look like that bad a deal, right? And then I'll tell you another really interesting thing. These biomarkers, we can do a kind of model. We're doing these models where they're telling us all sorts of interesting things. So, here's your cognitive battery. And you have test number 1, 2, 3, it doesn't matter what. And then let's put in functional status. And so that means you can make D. And that means you can make what's left over, which is G. Okay? And then you get your biomarker. Put the biomarker down here. Okay? And so now you can ask, does this biomarker, just pick one, have a relationship to these tests? That's the first question, and the question might be yes. And then if it does have a relationship to these tests, is it mediated through D or G or both or neither? See, and the model can tell you all of that. So what we're generally finding is most of these serum proteins, which are all inflammatory cytokines, have effects on cognition, but none of it is mediated directly. It's going always through the latent variable. And in the case of D maps to a network. And what I think that's trying to tell me is that the immune system is talking to networks. It's not eating your brain. When we think of inflammation, inflammation's related to dementia, you kind of think in your head that this and the CRP and your tumor necrosis factor alpha, it's going to your brain and eating it. It's just eating it and causing plaques and tangles. But what this is saying is it turns D on and off. And D is an entire network. But maybe it has no effect on G. And G's a network too. So that means it would be having specific effects on single networks and turning some on and some off, like a switch. And if that's true, then what it means is that D is dementia. It might mean that dementia is reversible and can be switched on or off by your inflammatory system, right? And some of that makes sense to me. For one thing, is we have examples. When people develop a wide variety of traumas, stress, and infectious diseases, they get cognitive impairment. And so you get the flu, just try going to work, right? It has nothing to do with how bad you feel. You feel bad with a head cold, but you do go to work on that day. But the day you get the flu, you can't think straight. And if I tested you, you'd have bad D. Now D is just a piece of your battery, so I'm not really sure I would find it in the whole battery. If I gave you a whole battery of tests, I bet you I wouldn't find much of an effect if you had the flu. But I bet you if I sucked D out of that battery, I'd find it. Or if I imaged your default mode network while you had the flu. And then there's going to be some cytokine floating around in your brain, in your bloodstream when you have the flu, and it's probably telling your default mode network to turn off for a while because we need you to go to bed. We don't need you to be thinking about things. You need to be just sitting there, right? And so this is what's called illness behavior, right? People behave in sick ways. You assume the sick role, and cytokines cause that. So now sometimes we treat diseases with cytokines like interferon, alpha interferon for hepatitis C, and you become depressed, or what we recognize as maybe depression, but I'll bet you that's bad D too, because I've modeled the cognitive correlates of depressive symptoms and it maps to the same network. You see? So there's a cytokine turning off, again, the default mode network. So one of the proteins in TARC that I've associated with D scores is tumor necrosis factor alpha. Now I got a bunch of them. So for a while I was thinking of developing a blood test. The slides here were, here's the pattern of 8 that's going to make a blood test for MCI. But the more I thought about it, the more I thought, this protein is related inversely to D, and that's dementia. So if I get rid of that protein, that's a treatment. That's not a blood test. Hell, that's an intervention. So, and then the thought hit me, wow, some of these probably already have FDA-approved agents. I could just give one. So I went through the PDR, show me these 8 proteins. Okay, show me every drug FDA-approved that's related to one of these 8 proteins. And when I got to tumor necrosis factor alpha, there were some. There were about 5 anti-tumor necrosis factor alpha agents indicated for arthritis and psoriasis. One of those is called Enbrel. So I just started Google, show me every study ever done with Enbrel and Alzheimer's and the same thing, and I get 100 YouTube videos of ordinary people who got Enbrel for their psoriasis and their dementia. Mom's dementia is gone. Look at this, people. And so they put it up on YouTube. And then I found out there's a dermatologist out at UCLA who's been swearing for years that this cures Alzheimer's in one day. And so he gives them Enbrel and their dementia is gone. And he has these guys on the video. And because nobody believes this is possible, because the whole world is thinking amyloid and how in the world could you make all this pathology go away in a day, they think he's a quack, right? And so his license is under investigation and all these pending lawsuits, but the whole time he's filed a use patent on it. He's flying people in from all over the world to Boca Raton, Florida, where he hangs them upside down, gives them a shot of Enbrel, and the next day their Alzheimer's is better. And so the thing is, I believe he might be onto something, because his protein just came up out of the TARC data, 2,000 people. And so it's definitely a modulator of the D-score. And he's got a drug that can modulate the D-score. Modulate that protein. The other thing is, one of the dirty little secrets of Alzheimer's is there's all these lesions in there, and Alzheimer got famous by describing them, but they are not really correlated with cognition. Now, maybe the p-value is significant in 52 people in an unadjusted model that was not even adjusted for age or anything, but basically amyloid is weakly related to cognition at about 0.2, which means 4% of the variance in an unadjusted model is related to amyloid lesions in your brain. So are you going to cure dementia by getting rid of that? You see? And tangles are better. They may explain twice as much variance. So, okay, 8% of the variance in your mini-mental score is related to your tangles. And if you there's one study where they actually put both in a multivariate model, and the tangles knock the amyloid out. So it's not the amyloid at all, it's the tangles, and even they only explain 5 to 10% of the variance in your mini-mental score unadjusted. So what kind of foundation is that for dementia research? So basically, if you think about networks are designed to resist the destruction of their nodes. That's one of the architectural advantages of evolving a brain that's a network. It didn't have to be that way. Nature came up with it. And it's just like the internet. We've evolved a similar structure because it's robust. And the whole idea of the internet is that it would survive nuclear war. So that's why they created it in the first place. But its design is to resist degradation. You can knock out the nodes of a network and life goes on. So similarly, nature somehow knows you could knock out individual neurons and that's not going to degrade information processing in the network. So again, why do you think tangles make dementia? And just a few neurons got killed. But hell, you can knock half of them out. You can take a child, and if they have epilepsy, take off the entire cortical hemisphere on one side and they'll grow up normally. Right? So, anything like that happening in Alzheimer's? Do you really think it's the pathology? You see, I wouldn't be surprised if the immune system is talking to networks and that's what dementia is all about. And if you turn the switch off, they'll come back. And they've lost 1 out of 3 neurons, so they won't remember anything that's happened in the last 5 years. They might have to go through rehabilitation to be brought back, but they wouldn't be demented anymore.
So is it Enbrel?
Yeah, that's what.
Are those effects permanent, or is it?
Well, I don't know. He's not a scientist. He hasn't published much. He's holding his cards close to his chest. But I'm trying to get out there and go see his data. I want him to show me his cards. So I'm thinking about going out there and taking his training. You know, he has these training programs. And if it works, I'd be willing to try it, just like I've tried rapamycin in some people, cautiously. But the point is that every single one of the proteins we associate with D-scores in TARC is a potential intervention. And maybe any one of them is weak, and you'd have to actually manipulate 5 of them at once, but then you're just talking about chemotherapy, right? So I think that's where the Alzheimer's treatment of the future is going to go. It's going to go to IV interventions against multiple inflammatory cytokines that are actually talking to your brain, not eating it. See? Because the individual neurons are expendable. Because nature knows that's why it built it as a network, is so you can lose neurons and it's no big deal.
Well, this is fascinating. Thank you, Don, for being here. Don is going to be for a few minutes in the hall to answer specific questions. We need to rest 10 minutes, be back at 2:45 for non-pharmacological interventions in dementia by Dr. Veronica Shedd. So just rest for a few minutes and Don will be available. Thank you.
Does it? Well, it probably kills neurons.